Two, 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 two. Check, 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 check. Check, check. 1, 2, 2, 2. All right. Two, 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 two. I'm gonna keep you post. I just jump back and forth. Okay. Check 1, 2, 2, 2, 2, 2. Check, check. You want more? Down? Less? Check, 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 check. 1, 2, 2, 2, 2. Check 1, 2, 2, 2, 2, 2, 2, 2, 2, 2. Right there, right there. Okay. I already gave her the lav. So as soon as we hit it, we'll go down. Okay. All right. All right. Thank you.
Wonderful.
So nice. Great to have you.
Forward and backwards.
Okay, forward and backwards. And pointer? Perfect. Okay. We're getting our...
I'll just get up and make like 100
2 seconds.
announcements.
2 seconds?
Do your bio, do the whole
No.
rigmarole.
Very short. Very short.
Okay. And we'll let you get. If you want to put your things
Yeah.
down up here.
Yeah, let me do that.
Janine got you a bottle of water.
Oh, thank you.
Great.
Where do you want me? Here? Okay, perfect.
And just so you know, we're going to be taking questions in the room by text.
Whoa, this is
I
interesting.
know, we're entering the modern age here, so Kathy and I will probably be asking.
Let me mute my phone. You know, I'm trying.
Okay, we're going to get started, but I'm going to need a mic for the question and answer.
Oh, you want it now? Whatever you want to do.
I'll
It'll
come
be-
back and get it. I just want to let you know. Yeah, but I need a mic to ask.
Good morning, everyone. Good morning. Thanks so much for joining us again for the second day of our annual conference for women living with metastatic breast cancer. Just want to welcome you all back, as well as the 70 people who are going to be watching this presentation as a webcast. So welcome them. Say good morning to them, please. We wish you could be with us, but we're glad you can join us over web streaming. We've already had a great morning. I heard that the yoga class was wonderful. And I know all of you visited the workshops this morning on bone mets, legal issues, and writing, and I hope that you all got lots of knowledge there. A couple of reminders. We will be pulling the drawings at noon, or 12:30 after the Q&A. You must be present to win, so please hang out. If you are on social media, on Twitter or Facebook, we encourage you to use our hashtag, which is LBBCMBCConf, to let people know about your experience here today. So I'm very honored to be able to introduce our speaker. Our session today is entitled Living Fully, Managing Symptoms and Side Effects, and I'm very honored to welcome Generosa Grana. Dr. Grana is the director of the MD Anderson Cancer Center at Cooper and head of the Division of Hematology and Medical Oncology at Cooper University Hospital in Camden, New Jersey, just over the river here. She serves as professor of medicine at Cooper Medical School of Rowan University and is adjunct professor of the Creel Institute for Medical Research in Camden. Dr. Grana has received numerous awards, including the Johnson & Johnson Community Health Crystal Award and the American Cancer Society Silver Chalice Award. Dr. Grana is a member of the Federal Advisory Committee on Breast Cancer in Young Women. And last but absolutely certainly not least, she is on our medical advisory board and speaks frequently on behalf of Living Beyond Breast Cancer. So I'd like to introduce her now.
Thank you. It's a pleasure to be here. And just to let you know that my work on the Federal Advisory Committee for Breast Cancer in Young Women, LBBC, is really highly recognized for the work that they're doing in the field of breast cancer in young women, metastatic disease, and all of their programs. So it's a pleasure to be here. So my topic is to talk about managing symptoms of the disease and side effects of treatment. And it's a bit of a piece of work to try to do that. So I'm going to give you a flyby view. I can't see these slides very well, so I have something here that'll guide me, so bear with me. What we will talk about is some of the common symptoms of breast cancer, and at the end, we'll have an opportunity to have questions so that hopefully we can address some of your issues. The key thing is that metastatic breast cancer and breast cancer of all types affects not just the woman, but the woman, her family, and her community. So it becomes critically important that you communicate with the team that's taking care of you so that these symptoms can be managed and that the side effects of treatment can be adequately dealt with. There are tremendous resources available both at your treatment center, online, and elsewhere. So as a very savvy consumer, as most of you are, the key is to take advantage of those resources and to be aware of the research that's going on, not just in the treatment of the disease, but also in symptom management. There's a tremendous amount of work being done looking at ways to manage neuropathy, looking at ways to manage aromatase inhibitor, arthritic symptoms, et cetera. So take advantage of some of that research and participate in studies if they're offered or are available to you. So again, we're going to move on and talk about symptoms of the disease and side effects of treatment. In general, the symptoms of breast cancer are myriad. It's an amazing disease. Many of you have experienced it. The symptoms are very different from early stage to localized to metastatic. Common ones include fatigue, and we'll talk about how to deal with that, anxiety and depression that comes with the diagnosis and the treatment and the whole kettle of fish. I'm going to come back to those too because there was just a publication from the American Society of Clinical Oncology. It's online, available to you, that really reviewed the management of those two as well as the management of neuropathy and actually came up with concrete guidelines as to things that they would recommend, things that they feel there is adequate data to support, and things that they don't feel are yet ready for prime time. So we're going to come back to that. But in general, the symptoms of the disease depend on the sites in which this disease has metastasized and the extent of metastasis. So we have very often the woman who is completely asymptomatic. Her metastatic disease was diagnosed on an abnormal laboratory study, be either an alkaline phosphatase or a liver function study showing some liver dysfunction, a white count or hemoglobin showing bone marrow involvement, or a scan that shows bone lesions that are asymptomatic, liver, lung lesions that are asymptomatic. So a large number of women, especially with this new era of imaging and laboratory studies, are going to be found to have asymptomatic metastatic disease, and there's really not much to manage in those women. In other cases, we have symptomatic disease, and the symptoms can vary, again, based on how extensive the disease is and where the disease is. We can have mild symptoms, some cough or liver nodules or pleural fluid, some abdominal symptoms, or we can have what is known as visceral crisis. When people talk about that, what does that really mean? That means someone who has pretty extensive disease in the lung or in the liver. Someone may also have neurologic symptoms. So the important thing when we talk about symptoms is that they need to be managed because it affects the drugs that are available to you. It affects your quality of life. It affects what is done with your chemotherapy regimen, et cetera. So again, it varies in terms of the patient and the presentation and a key element. You've heard this morning about some of the bone issues that can occur with metastatic disease. So we know that bone involvement can be asymptomatic. The woman who has some bone lesions and you look at her scan and you're really impressed and you look at her and she has not one symptom in the world, that's a wonderful thing. Or you can have patients who have pain, either diffuse or focal pain. You can have fractures as the first presentation. You can have calcium issues, nerve root issues from spinal cord involvement. So again, bone disease is very important in breast cancer. It's probably the first or second site most common for breast cancer to involve. Lymph nodes probably are the first and most common. Bone, I would say, is probably number 2. So it's something that many of you deal with. Lung, pleura, not so much lung, but pleura is very common. The concept that there's fluid in the lung, fluid around the lung, not in the lung, can be common. It can cause shortness of breath. It can cause pleuritic chest pain, pain when you take a deep breath. Abdominal symptoms can occur. And again, most of these have very simple fixes. For example, the pleural fluid. The pleural fluid can be relieved, can be removed. The procedures can be done to keep it from reaccumulating. So the key is recognizing it and dealing with it appropriately. How do we manage some of the symptoms of the disease? Well, again, the strategies that are available to us are myriad, more so today than ever before. It includes radiation. It includes, in many cases, hormone therapy, chemotherapy, biologic agents. You've heard this morning about the bone-targeted therapies, Xgeva, Zometa, and some of the newer compounds that are on the block. The key is to pick amongst those the things that are appropriate for the patient in question. And you're going to pick a different approach based on the severity of the disease and the symptom complex of the patient. I'm not going to talk today about how you go from treatment to treatment. Many of you know that if you're estrogen receptor positive, we try to keep those women on hormonal therapy for as long as possible, because although some of the hormones are wicked in their side effects, they're much easier than many chemotherapy options. For the woman who's triple negative, we try to find the most effective and most tolerable chemotherapy options. For the HER2 positive woman, we often try to find the best combinations with either Herceptin, now Perjeta, or Tykerb that will give you great results but great tolerability. So again, the strategies that we use to treat the symptoms of breast cancer depend on the patient, depend on the disease site, and depend on the severity of the disease. I come back, though, to the bottom and talk about the team members, because your team is really a critical part, and you need a team that is a multidisciplinary team. You hear about that a lot, but what does it really mean? Metastatic breast cancer is not something that is managed by one person alone. Many of you have an oncologist and a relationship with an oncologist. But oftentimes a radiation oncologist is part of the picture. A surgeon may be part of the picture because something needs to be biopsied, something needs to be removed. But there are other very important pieces of that team. Our behavioral health colleagues are very important because, again, the psychological sequelae of this disease are enormous. Social workers are important. There's data that has shown that support groups, particularly in metastatic disease, can actually improve survival from breast cancer. So again, taking all of those pieces involved and putting a team together that works with you to manage the disease. I didn't add this, but I will at the very end of my presentation. Many programs are now developing palliative care teams. What are palliative care teams? They're teams that focus on symptom management, teams that will have specific expertise in dealing with neuropathy and dealing with some of the myriads of symptoms that we have. And then there are also integrative medicine teams that are being developed at many programs that add not just the medical treatments, but also some of the complementary therapies, mind-body therapies, and some of the Eastern therapies, I guess, Eastern or Western? Eastern, I guess. That many of you I know are already taking part of. So again, all of those are also part of your team. And it's important that your team members know each other and know what each other is doing, because one of the worst things you can do is be getting a treatment from someone that's causing symptoms or issues that your other team member doesn't know about and won't be able to address. So very important to have a team that's defined that you can communicate with. I'm not going to focus on bone disease at all because, again, you've heard about it this morning. The main thing for bone disease is prevention first, and in that case, we use Zometa, Xgeva. We can radiate areas before they become problematic. Once we go beyond the prevention and we talk about treatment, there's, again, a big role for radiation in management of bone disease. Quadramet is a drug that I like a lot. It's an intravenous radioactive compound that can treat multiple sites of disease. And again, a lot of other issues that can be done in dealing with a woman with bone involvement, managing calcium, managing pain, all become part of the management of bone disease. Lung disease, I talked about again. I'm not going to spend any significant time. We can come back to this. These are just two of the symptoms that we can deal with. I guess I should have added to the symptom complex, something that I'll talk about a little bit later, this pneumonitis. When you hear about Afinitor, and some of you have heard about that wonderful new drug, pneumonitis, inflammation of the lung, it's actually not just with Afinitor. You can see it with Taxol, with Abraxane, with other compounds. So your team is key in dealing with some of these side effects. Many other symptoms are part of the symptom complex that comes with metastatic breast cancer. And the key is, as I've been saying, that the management depends on the severity, and it also depends on the patient. Sometimes you need to, because of the organ involved, select different drugs. If the liver is affected, there are certain drugs that can't be used. If your ALT, AST, bilirubin are elevated significantly, Gemsar may be a better choice than other drugs. So choosing the right drug will be impacted upon. Depending on symptoms of disease and other toxicity, the change needs to be made in drugs dose. So you may need to change dose and schedule, and we'll come back to that. You may need to add adjunct drugs to your cocktail to deal with specific symptoms. And again, the key is communicating with your team so we can minimize the impact on your quality of life, so that we can avoid hospitalizations if at all possible, because no one wants to spend precious time in a hospital room that, despite our beautiful new rooms that hospitals are building, are never fun or great for patients and families. And again, ideally to minimize the impact on your treatment, to minimize those dose reductions, to minimize those treatment interruptions. So if we can identify the symptoms and the signs early, we have a much better way of addressing them. What has changed tremendously in the last 5 years has been the complexity that we are dealing with when we talk about side effects of treatment. In the past, the medical oncologist was a simple, we didn't do much internal medicine. We trained as internists, but we didn't have to practice it very much. We dealt with chemotherapy, hormone therapy, et cetera. I can't tell you the last time I had to manage hypertension. I can't tell you the last time I had to manage endocrine disorders. And now, as we see these drugs and these combinations, the management is becoming increasingly complex, and oncologists are being asked to know and do things that they didn't do before. Some of us that are old and are not adapting well use our colleagues, our primary care physicians, much better. So I've become very good friends with my primary care physicians because, again, if I'm having issues with hypertension, some of you will remember Avastin, that drug that has gone out of vogue this year, but maybe will come in vogue again. There are others like it, though. And the problem with Avastin is hypertension was a major issue. Rare eye changes, kidney function, protein loss, complexity of symptoms that oncologists were unprepared for. And what is happening now is we're seeing more of these new drugs with complex side effects. And as we combine these drugs together, we're seeing toxicity that we did not have in the past, and I'm going to come back to that. In the past, we had simple things. We had hormones, and we had chemotherapy, and we had maybe 10 drugs. Now we have 5 or 6 hormones, 15 plus chemotherapy agents, and all of the new biologic compounds that are on the market. All the HER2-neu-based therapies are 10 years old. A lot of the new compounds, like the mTOR inhibitor, Afinitor. So we are really changing the side effects that we're seeing from chemotherapy, and as a result, we need to work much harder at managing these. I'm going to walk you through something that you may or may not be aware of, and that is the common toxicity criteria. Why is it important? Because when you go to your oncologist is trying to figure out how severe the side effects that you are experiencing are, because that gives him a sense, based on data that's been published for the regimen that you're on, of what they should be doing. So the National Cancer Institute published and updated criteria for treatment. It's used for commonly reporting side effects of therapy, so clinical trials use this as a way of reporting data. It's used for dose modification, and I'll show you that in a few minutes. And it's also used, importantly, to help us guide treatment of some of those side effects. So again, this is one of the versions. It's called the Common Terminology Criteria for Adverse Events. It was last updated. There may be even a newer version than this. This is what I happened to find some slides on. But again, this is what it looks like. It's a grading system, grade 1 through 5. You don't want to be a 5. What does 5 mean? Not good. I'd like to keep my toxicity in the 1 range because that tells me you are having side effects. They're manageable. I don't need to change your dose. I don't need to make any adjustments. I just need to monitor. Grade 2, 3, starting to get significant impact on activity of daily living. For example, grade 3 neuropathy, a woman can't button buttons, can't pick up cups, is shuffling her gait. That's really significant. That's grade 3, and there are specific guidelines as to what to do with those toxicities. I wanted to give you 2 examples, and you probably can't read this, neither can I, but one of the common ones, it's a book, so it's a book that every oncologist and every clinical trials nurse has. It's now online, and every organ system is accounted for in this book. Skin, general symptoms like fatigue, pulmonary, GI, endocrine, et cetera, and they really go into great detail. I picked this one for skin because some of you who have Zalota get hand-foot syndrome, palmar-plantar syndrome, and it actually can be graded. So you can have just a little redness, a little bit of darkening of the skin, or you can have peeling, blistering, which is grade 3, or you can have such severe changes that you have pain, blistering, can't walk. So again, grade 1 through 3, depending on the severity of symptoms, and it guides you in terms of what you need to do for that particular woman. The next one I picked was neuropathy, because most of you have heard about neuropathy. Some of you, unfortunately, have probably experienced it either from adjuvant chemotherapy when you had early stage disease or now from your metastatic disease. But neuropathy is actually quite complex, and your oncologist needs to try to figure out, is it sensory, you can't feel, is it painful neuropathy, is it motor neuropathy? And again, depending on the grade of the neuropathy, you're going to do different things. Most clinical trials tell you that if someone has grade 3, you have to stop your drug, hold your drug, stay put until it improves to grade 1, and then you can often go back with a dose reduction. So it's not as simple as just watching. It often includes significant modification to your schedule. Now, what happens if it doesn't improve? If it doesn't improve, you change your drug, because the problem with neuropathy and many of the other side effects are that if you continue your drug unchanged without any modification, you're going to make the symptoms worse and potentially permanent. So again, a slide like this, if you go online and you look up common toxicity criteria, you'll get these slides that I have, and you can look up whatever toxicity you're having from your chemotherapy regimen. Now we're going to move and talk about some of the hormonals and some of the interesting new worlds that Afinitor and others have brought to the hormonal arena. Hormonal therapy for many years was tamoxifen and Megace. That was it. That was the entirety of our hormonal armamentarium. About 15 years ago, we added the aromatase inhibitors. The original ones were not so nice. Aminoglutathamide was an ugly aromatase inhibitor, but we now have better. So we have 3 aromatase inhibitors, Arimidex, Letrozole, Aromacin. We have Faslodex. And now we've moved into a world of combination therapy with aromatase inhibitors and others. There was a trial presented at San Antonio 2 years ago that suggested that potentially Arimidex and Faslodex together may give you additional benefit if a woman never had tamoxifen the first go-round. We now have data that the aromatase inhibitors can be combined with her 2 new targeted therapies, Tykerb, Herceptin. And obviously, we have data on aromatase inhibitors and Afinitor. So clearly, these drugs are very effective. Alone, they have side effects that I'm going to mention. When you add these other compounds to them, the toxicity profile changes dramatically. So what are some of the symptoms, some of the common toxicities of hormonal therapy? Who has not had hot flashes and night sweats from their hormonal therapy? They are unfortunately, well, I shouldn't say that because some women are very lucky. The older woman usually, because she's gone through menopause, she's further in her field, and some older women do beautifully, have no symptoms, but a lot of women still complain of drenching hot flashes, night sweats, sleep disturbance that comes with the night sweats, and the whole vasomotor symptom complex. Vaginal symptoms, dryness or discharge. Arthritic symptoms from the aromatase inhibitors. I'm going to come back and talk about that. And so those are very common. I'm going to show you some data. But then when we add Tykerb to the aromatase inhibitors, we're adding the rashes, we're adding the diarrhea and the GI symptoms. When we add Afinitor to the aromatase inhibitor, we're adding the rashes, the mouth sores, the pneumonitis, the fatigue. So again, we're taking drugs that by themselves were not bad. By themselves were pretty reasonable, friendly drugs. And now we're completely changing the safety and toxicity profile. This is a very old slide. Dr. Sharon, who's in this room, probably doesn't remember this trial. This was the ATTACK trial. It was the first of the trials that was presented in early stage breast cancer looking at Arimidex versus tamoxifen. And it had an interesting caveat. It had a combination arm. So a third of the women got Arimidex, a third got tamoxifen, and a third got the combination. The combination didn't go anywhere because it was no better than just plain old tamoxifen. But when you look at the side effects, I put an abbreviated list of side effects on this. So there were clotting issues with tamoxifen, more so than with the aromatase inhibitor, we know that. Endometrial cancer slightly more with tamoxifen than with the aromatase inhibitor. Hot flashes were pretty similar. I think in here, the hot flashes, 34%, 39% high in both, I would argue. Vaginal discharge, much more with tamoxifen. The thing that I think is impressive is what they call musculoskeletal symptoms. You would call them arthritic aches and pains, so arthralgias. If you look, tamoxifen causes this in approximately 20% of women. The aromatase inhibitors, probably closer to 30% of women. But if you really start delving into it and asking women, it's probably closer to 50%. And the severity is very different. Tamoxifen gives you arthritic symptoms. They're mild, they are noticeable, but usually they're not terrible. The aromatase inhibitors, very different. About 10% of women end up having to discontinue the drugs because they're miserable. Now, it's one thing to discontinue the drug if you have early stage breast cancer. It's a very different thing to discontinue the drug if you have metastatic disease. So again, we are much more aggressive in dealing with these symptoms in a woman who has metastatic disease rather than a woman who has early stage breast cancer. So this is just a sort of brief look of what some of the symptoms and side effects are with these drugs. Now, what do you do to manage the symptoms that go with the aromatase inhibitors? Oftentimes, lifestyle change can make a dramatic impact. And there have been, for the hot flashes and the night sweats, the first thing I talk about is exercise, alcohol avoidance, caffeine avoidance. For some women, it makes it tolerable. For other women, it doesn't help one iota, but it can't hurt. So those are the first things that I go to. And then we talk about drug therapy, because there are drugs we can use. There have been a series of studies done at the Mayo Clinic. There's a gentleman there, I'm totally blocking on his name, Lopresti, who has done tremendous work trying different things to deal with the hot flashes and the night sweats associated with hormone therapy. So they've done studies looking at Effexor. They've done studies looking at Neurontin or gabapentin. They've done some negative studies. So vitamin E didn't make any difference. There's always a placebo effect. If you do a study and you're looking at hot flashes and night sweats, 20 to 30% of women with a placebo will improve. And so it's hard to tell the difference with your intervention. But again, much more is being done to look at this. But I think the key is to really focus on lifestyle. Drug therapy for hot flashes, antidepressants, gabapentin, others. I always look at other strategies, sort of mind-body interventions, potentially acupuncture. There's some data supporting acupuncture. Again, yoga, all of those things that can be helpful. For the arthralgias, not as much is out there. There was a study presented this year at San Antonio showing that exercise can be very helpful. So again, lifestyle. There is a study going on right now. We have not opened it because we thought it would be a hard study to open, but giving women a sub-Q pellet of androgen, testosterone, injected subcutaneously in a pellet form, and the idea is that potentially that may be the culprit in the arthritis. We felt it was a little difficult to enroll patients into a placebo pellet implantation, so we did not open that study. Now, again, as we look at, let me see, where are we? Okay, so we have, did I go back? Let me go back one, I think. Yes, okay. So again, I think the key is that there are things we can do, and I'm missing a page here. Perfect. For the hormonal treatments. Now the problem then becomes, as you add other drugs to your already not perfect hormone, what happens? So I listed here approved indications. So we have ticarbin letrozole as an approved indication in the first-line setting for women with HER2/neu positive metastatic disease. We have Afinitor, Everolimus, and Aromacin approved in the first-line setting, or no, it's actually in the second-line setting or first, for metastatic disease. And then we have a bunch of studies going on that include aromatase inhibitors or Faslodex, hormonal therapy, but combined with some of the new targeted drugs, some of the cyclin-dependent kinases and other compounds. So it's really becoming a changing world in terms of the toxicities we're experiencing. This is a list of some of the side effects that were reported when you add ticarb to letrozole. So you take a drug that has known side effects, and now all of a sudden you really have a very different disease. I don't know if you can see this at all, but here, diarrhea goes from about 20% when you have, and most of that is very mild, when you have letrozole alone, now to 64% when you add ticarbin letrozole, and you have 9% of patients that have grade 3 diarrhea. So you can see that not only are you adding significantly to the number of patients that have the symptom, but you're adding to the severity. Nausea significantly increased. Rash hardly seen with letrozole or not with any significance, and 44% of patients on the ticarb arm have rash as one of the components. So you can see that again, even with the drug that's an oral compound. When ticarb first came on the market, we were all excited because here's an oral compound for HER2/neu positive disease. Well, yes, it's an oral compound and it's an active compound, and it does great things, but it clearly changes what we need to do to manage it. This is data from that original trial with ticarb, and they had 60 patients with grade 3 or 4 diarrhea. 15% of them had to discontinue drug, 20% had dose reduction, 36% had dose interruption, and 30% had required supportive measures to deal with the diarrhea. So you can see that these are not harmless side effects, but it is important because the one thing that happened on here, 15% of patients discontinued the drug. That's what we want to avoid. We want to manage the side effects to avoid discontinuation and keep you on an active compound. Not only diarrhea and not only rash, but oftentimes the bane of our existence is liver function abnormalities, laboratory abnormalities. So this is also from the ticarb days, showing that a significant number of women will have abnormalities in ALT, AST, bilirubin that lead to changes in therapy or dose modification. So it's a new world as we add these compounds to the management of metastatic disease. This is now moving on to Afinitor. And Afinitor is not a drug that's only used for breast cancer. You only are focusing on that, but it's actually approved for some neuroendocrine tumors, and it's approved earliest, actually, for renal cell carcinoma. And I think, although this data would not suggest it, I think the side effects that these patients experience are different in endocrine, different in renal cell, and different in breast. So I don't know if it's the population of patient, if it's the organ system, but I think there are significant differences. With neuroendocrine cancers, you actually get headache, you get fluid retention, et cetera. With breast, the major problems when you deal with metastatic breast with Afinitor are the mouth sores, and they're very distinct and very different from the mouth sores that women get with chemotherapy. The lung toxicity, the fatigue, and the rash. Those are really the key issues. This is data looking again at the 3 sites. This is from the package insert. I wanted to find something that was easily available to you. You can review this. But Bolero was the trial that led to the approval of Afinitor and Aromasin. And you can see that mouth sores occurred in 67% of patients. Infections were increased. Pneumonitis, that concept of lung toxicity for a mechanism we don't understand, in about 19 to 20% of patients, and rashes in about 40% of patients. So you can see that these are real and vary, because if you look at the stomatitis, it's not necessarily just dose. With Afinitor and Aromasin, the starting dose was 10 milligrams. A fair number of patients needed a dose reduction. So dose is a factor, but it's also, I think, potentially the patient population. This is looking at, again, a few slides looking at the mouth sores, and really the mouth sores are frequent and they need to be managed. There's a lot of work right now looking at ways of preventing mouth sores. There's a study being done using a steroid mouthwash to see if it can prevent it. I find that if you start a little bit lower than 10%, you often can avoid that, because the first patient I started on Afinitor Aromasin ended up hospitalized for dehydration because her mouth sores were so severe that she couldn't eat. So clearly this is something that we're getting better at managing, we're getting better at recognizing, and we're having some studies that are showing us that there are things we can do. The rash, I think, is less problematic. Many women experience the rash. Again, I showed you about 40% of women experience an Afinitor rash, but it's usually a fine rash, acne-like, not particularly problematic. The mouth sores are usually the first problem that you experience with this drug. 2 to 3 weeks is the typical onset, the rash about the same. The pneumonitis actually is much more unpredictable. This is the data on the pneumonitis. And again, in about 20% of patients with metastatic breast cancer, pneumonitis is an issue. And this is what the pneumonitis looks like. It can actually look very, it can be difficult to diagnose. Sometimes you do a chest x-ray and see absolutely nothing. I had a patient last week who was having fevers, et cetera, and chest x-ray didn't show much, but the CAT scan showed these ground glass opacities and typical. The time frame is different. The time frame is 2 to 6 months into the Afinitor therapy. So you need to stay alert to this, and patients need to report cough, shortness of breath, lack of the same exercise capacity that they had previously, because this is something that does mean an important change needs to happen. If it's mild, you can just discontinue the drug for a short time and try it again. But when you're starting to get to dose, grade 2 and 3, you're going to have to think seriously about whether you're going to continue this drug. This is a slide that talks about the recommendations for the pneumonitis. I think the key is really being selective of the patient that you're going to put on Afinitor. If you have someone that has emphysema, that has significant lung involvement from their cancer, or has had radiation pneumonitis or other, that's probably not a patient that you're going to pick Afinitor for, and you're going to move on to other drugs. And again, this is the grading classification for Afinitor, and treatment with steroids is if it's significant enough, you need to treat with corticosteroids, and often high doses of corticosteroids until the symptoms improve. So clearly, a drug, Aromasin, that was not known for any of these side effects, and now that we've added this mTOR inhibitor, a whole new world of side effects. And this is one of the new mTOR inhibitors. There will be others, because there are several of these compounds in clinical trials, so we are going to need to become much savvier. Let's talk about, again, other side effects associated with chemotherapy. Who hasn't had the skin changes and the hair loss associated with chemotherapy? Even with hormone therapy, there are case reports of significant hair loss with hormone therapy. The fatigue, hypertension can be an issue with some drugs. Lots of GI toxicity, ranging from reflux to nausea, vomiting, diarrhea, etc. Neuropathy. Any organ system can be affected by these drugs. Kidney dysfunction, neurologic dysfunction, endocrine dysfunction. As we look at some of the new drugs, we actually, there's a new drug for melanoma, and there are studies being done in breast cancer. Very interesting drug. A lot of endocrine disorders, hypothyroidism, hyperthyroidism, lots of autoimmune toxicity. So again, I think we are going to need to be better at recognizing this. So in general, I would say that my message in terms of managing chemotherapy side effects is to communicate with your team. No symptom is too insignificant. No symptom should be kept to yourself, because it may be the symptom that alerts someone to look further. There are many approaches to manage side effects. Some of them include stopping your drug for a little bit. Some of them include modifying your dose. Some of them include adding ancillary drugs, for example, for the GI symptoms. And some of them actually are complete discontinuation of that drug because the symptoms are life-threatening and dose modification is not enough. So the key is really managing and communicating. So now let's look at, all right. Let me go back. I think this may be out of order, but let's see. In 2014, ASCO published guidelines as to the management of 3 symptom complexes that are available on their website, and I urge you to look at them. The guidelines focused on both prevention and treatment of fatigue, anxiety and depression, and neuropathy. And these guidelines were pulled together by a panel of experts that reviewed the available research, the available clinical evidence, and made specific recommendations where they thought there was enough data to make recommendations. They reviewed the literature. They focused, though, and I think this is important, they focused on published phase 2 and 3 clinical trials. So they didn't focus on small studies that it might have shown a benefit, and they acknowledged the limitations of this. And they really came to some interesting conclusions. So let's look at a couple of these. Neuropathy, we talked about, common, associated with multiple commonly used chemotherapy drugs and combinations of drugs. It's much more common when a woman is using platinum compounds, so cisplatin, carboplatin, Taxol, Taxotere, ixabepilone. Some of the newer drugs in breast cancer have neuropathy as a major component. Severity, onset, improvement, all vary and depend on the drug and depend on the woman. Some of you are going into new chemotherapy regimens with already established neuropathy, either from your early stage breast cancer treatment or from your previous breast cancer treatment. So again, the reversibility of neuropathy and the approaches that are available to you vary from woman to woman. These are the recommendations from this panel on prevention of neuropathy. And they basically concluded, and I'm going to read from this slide, there are no established agents recommended for the prevention of neuropathy in cancer patients undergoing treatment with neurotoxic agents. They felt that there was a paucity of high-quality, evidence-based literature. They recommended not offering some of the compounds that are on this agent, glutathione, amitriptyline, amifostine. I totally agree with amifostine. I don't know if any of you have seen ethiol, amifostine. It's a drug that has a lot of toxicity, intravenous, not a great drug. But again, this is a whole list of the agents that this panel felt were not supported in terms of prevention. They felt that Effexor was not recommended for routine use, but While data supports its potential utility, data is not strong enough to recommend it. So again, remember, this is a panel. They're reviewing the data that's in the public domain. And I think you and your oncologists have to have a discussion, because I can tell you that I do some things for prevention of neuropathy that I do with my own patients. I think glutamine may be helpful. The B vitamins may be helpful. So again, I think there are things that you can talk to your oncologist, but go back to this, because this I thought was very helpful. How about treatment of neuropathy once it's established? They suggested potentially using Cymbalta. They do not recommend the tricyclic antidepressants. I'm not so completely in agreement with that. They did say that it's reasonable to try. And again, for some patients, particularly those that are having a lot of symptoms at night, the tricyclic antidepressants can be very helpful. Gabapentin and pregabalin, they thought were reasonable to try. Pregabalin is Lyrica. So gabapentin is Neurontin, and Lyrica, they felt were reasonable to try. And there's a topical gel, which I personally have not used, that is a combination of baclofen, amitriptyline, and ketamine. Ketamine is an anesthetic. This is a topical gel. They felt reasonable to try. I have never used it and wouldn't even know where to begin the compounding process, but these are compounds that need to be mixed. So clearly the panel felt that there were some things that are reasonable to try. The data is not perfect. I usually refer my patients who have significant neuropathy after I get through my Neurontin or my Lyrica or my Cymbalta. I send them to palliative care. Mark Angelo then tries other things, and I find that it's very helpful to get another set of eyes to look at the symptom complex. Fatigue, the guidelines focused on fatigue, but they really didn't focus on fatigue in patients with metastatic disease. They focused on fatigue in patients who have finished their early cancer treatment and are 1 year or 2 years out from their treatment. They felt that it was potentially this could be applicable. Their recommendations may be applicable to the metastatic setting, but again, it's a different world, so just keep that in mind. They felt that the important thing was screening patients for fatigue and screening patients for potentially reversible contributors to fatigue. So what could some of those contributors be? Medications that you might be taking that could contribute, other drugs that are effective, conditions such as hypothyroidism, anemia, other agents. And as you identify those and treat them, you may be able to make a significant difference. Their recommendations were to educate patients and to educate them about the differences between normal fatigue that a person has on an ongoing basis versus cancer-related fatigue, and to address all of these things, potentially to look at physical therapy. And I think there's a whole body of research looking at physical therapy, cancer rehab programs for patients with some of these side effects to alleviate them, to look at psychosocial interventions, to look at mind-body interventions, et cetera, and to try some pharmacologic therapy. But again, they really did not feel strongly that some of the Ritalins of the world or some of the other psychotropic drugs might be beneficial. With anxiety and depression, the panel felt that, again, this was very important and that the key was screening patients for anxiety and depression and then instituting something to deal with them, because this is something that we actually have a lot of things that we can do. Once you identify potential medical causes, so again, the hypothyroidism, the anemia, and the other symptoms, and treat those, you can actually try lots of different drug therapies in the psychological armamentarium. Behavioral health experts are fantastic at this. And the key is not just medication, but medication, counseling, and all of those other interventions. I come to this because I think this is very important. The potential resources that are available to you at your center or elsewhere in your community. Think about a palliative care team. They're phenomenal at dealing with symptoms of therapy. They often are internists that have moved on and have gotten board certification in palliative care. Some of them are oncologists who've gotten board certification in palliative care, but they're clearly people whose entire area of interest is symptom management. They don't give chemotherapy. They don't manage your cancer. They work as an adjunct with your team to manage your symptoms. We have a gentleman, Mark Angelo, who's fantastic. Many nursing professionals are part of these teams, nurse practitioners or master's prepared nurses, and education is equally important in those teams in terms of helping patients deal with their side effects. I think the other important adjunct is appropriate pain management teams. We now have teams that don't just give you medications, but really can address procedures for certain painful areas, topical anesthetics, that ketamine that I mentioned in the earlier slide. There's some studies that are being done looking at ketamine for post-mastectomy pain in the chest wall. So again, some of the anesthesia pain management focused programs can be very helpful. And then I come back to this, the integrative complementary medicine programs that are increasing in number across the country. Most large cancer centers are developing them if they don't already have them. And they really have some very interesting potential strategies, looking at acupuncture, looking at more holistic approaches. If you're considering complementary integrative therapy, however top name you want to give it though, I urge you before you do it to look at the NIH website. The NIH has a Center for Complementary and Alternative Medicine. And on their website, they actually review a lot of the ongoing trials that are being done in this field. They review the data that's available on some of the techniques that you're going to be looking into. So don't blindly march into some of these more unusual practices without having done your research. Be the educated consumer that I know you are, because this is an area that I think can be a difficult minefield to navigate. So in summary, dealing with this disease and with the symptoms of the disease and the side effects that come from the treatment of this disease requires communication, requires a team effort, you, your family, your healthcare team, and it can be a large team because there are many people with different expertise that can be tremendously helpful in helping you manage this. Use all of the resources that are available because the goal is to minimize the impact of both the disease and the drugs that you're getting to really maintain and optimize your quality of life and to focus on a positive future. So I'll stop here.
Thank you so much, Dr. Grana. That was a wonderful presentation. We're going to take questions now, and we're taking questions via text. The number is up on the screen. And if you are not comfortable texting, but you have a question, there are pads and pens on the table, and we'll have a staff person walking around to pick up your questions.
And I'll be the first to tell you when I don't know anything about it.
Okay, I'll take the first question. For fatigue, there's a drug called modafinil, which is a non-stimulant way to focus through fatigue, but it requires pre-authorization and is only allowed for people with sleep apnea. How can you get around that?
Oy, I honestly don't know. Go back to the panel, go back to those ASCO guidelines and see what data, because they actually have references at the back of the guidelines with the pertinent studies addressing each of these areas. I think the insurance issue is a whole other world, though. It's very difficult to get things approved if you don't meet the indication, not just for supportive drugs, but for actual treatment drugs. So I can't help you with that one. I have no idea how you would get this approved.
Thanks, Dr. Grana. Our next question is about sexual health. Can you comment on sexual and vaginal health, specifically dryness and pain?
Very common and very, very important. I think, and I talk to my patients about this, this is a discussion between the couple. Because oftentimes you need to make changes to what you're doing and how you're doing it to make it comfortable and positive for both of you. So there are things you can do. If a woman is estrogen receptor negative, we're much more likely to be very comfortable with hormonal strategies for vaginal dryness and pain with intercourse. There is really no great downside if you're estrogen negative in using some of those things, and nothing heals the vagina as well as estrogen does. So even if a woman is estrogen positive, I'm often very likely to say that it's okay to use a short course of an estrogen-based compound to heal the lining of the vagina, and then you maintain it. You don't need to stay on the estrogen, but the other important thing is estrogen, the estrogen ring, Vagifem. Both are compounds that have estrogen, but that seem to have very little absorption. Most of their effect is locally. So I tend to go to those first, but if someone has a really, really significant amount of atrophy, you're going to need more than those compounds, and that's where a very short course, even a couple of weeks or a month, of a vaginal estrogen may be helpful. But this is a communication issue with your partner, with your oncologist, because there are things that can be done. And nobody should be so dogmatic that they will say, no, you can't use it because you have metastatic disease. Your sexual health is as important as your metastatic disease. So I would say that it's definitely needs to be approached.
Thanks, Dr. Grana. Another question. If you experience neuropathy, what makes more sense, to work with a palliative care team or with a neurologist?
You know, I think it depends on what's available to you. I don't send people to neurologists very much in my area because I have an excellent palliative care physician who is really attuned to management of neuropathy. And I think he spends a lot of time. He spends an inordinate amount of time with the patient trying to grapple, and I have a great communication with him. So we work together as a team. If you don't have that, I think neurologists have done this. Neurologists are not as knowledgeable about the chemotherapy-induced neuropathy is not exactly the same as your diabetic neuropathy, which is where most of the neurology professionals are comfortable. They see a lot of diabetic neuropathy. So I tend to pick and choose. If I have a good palliative care doc, I'm going to use them. And if not, but don't tell my neurologist.
Thank you, Dr. Grana. Our next question is about exercise. Regarding exercise to ease pain exercise to ease pain on AIs, what type of exercise is recommended?
I think that's less than clear. So there is data that, first of all, exercise is beneficial in whatever form. For early stage breast cancer, we have data that exercise and low-fat diet is helpful at preventing or lowering the risk of recurrence and improving outcome. There was a study done in California. Some of the studies now are using aerobic exercises. We know that for lymphedema, weight-bearing exercises, small weights, not exorbitant weights, are helpful. So I think it's less important what you do than that you do it and that you do it as much as you can. If there is a question, I think, again, a physical therapy consultation is always helpful. And more programs are adding physical therapy rehab components to the cancer program. We don't have one yet. We have a woman that we work with, a team actually, not a woman, but who does a lot of work with lymphedema, so we send some of our patients to her for management. But I don't think it's as critical what type. Walking, fantastic. Light weights, fantastic. I think it's the combination.
Thanks, Dr. Thank you, Dr. Grana. I lost my power here. Since we're talking about lymphedema, we had a question about what we know about lymph node transplantation.
We know very little. So do all of you know what that is? So lymphedema, obviously you all know, is the swelling that occurs to women after they've had procedures affecting the lymphatic drainage. Higher risk if a woman has had more lymph nodes removed, higher even if she's had radiation on top of lymph node removal. So we see very little now that we're doing sentinel lymph node biopsies. In the past, when we were removing 20, 30 lymph nodes and then doing radiation, much higher rate. The problem is, if you institute management early, it can be well managed for, or actually virtually disappear as long as you stay on top of it. Some women have very severe lymphedema, and the problem with lymphedema is not just cosmetic, but it's also functional and it's also infection. Some women get recurrent cellulitis of the arm that can become very severe systemic infection. You can go from a little redness in your hand to rip-roaring sepsis because it just does. So a lot of people have tried different things. Penn did a series of studies with exercise, physical therapy using weights, and they showed that you can improve lymphedema, and potentially in high-risk patients, you can decrease the risk of lymphedema by doing an aggressive regimen. So then there's this concept that if the problem is lack of lymph nodes, if you take healthy lymph nodes from another part of your body and transplant them into that area, you might be able to improve it. You might be able to reverse it. There was a study done in France, and I can honestly tell you I don't know enough about this, but there was a study done in France that showed that a number of patients improved significantly. They had about 400 some patients that were part of that study. They showed improvement. Our biggest worry is worsening because you're adding another surgical procedure to an area that's already a problem. They showed a large number of patients improved. There are people in the United States that are trying this procedure. MD Anderson has a plastic surgeon that's doing some of these procedures. There's a surgeon at Penn who's starting to do a few of these. I would probably say that I'm not convinced it's ready for prime time yet. I don't think we've seen enough research. I'm not sure that the people that are doing it have done enough of them. So in my own personal practice, I tend to dissuade patients right now. I may change my mind in a couple of years once I see more data and see more of our plastic surgeons and breast surgeons getting on board.
Thank you. We have a number of questions about antidepressants. This first one, the questioner is saying that one side effect of Neurontin is depression. And how do you deal with a patient that you might see who already has a history of depression, and would you prescribe Neurontin in that case?
Neurontin is an interesting drug, and the key, I think, for Neurontin is escalating the dose slowly. If you start a patient on the recommended dose of 300 milligrams 3 times a day, they go to sleep, and it's just a very sedating drug. On the other hand, if you start the patient at 100 milligrams 3 times a day for a week, and then 200 3 times a day for a week, and then you get to the 300, you're much more likely to build tolerance, and you're much more likely to get to the desired dose. For neuropathy, patients actually can be on significantly higher doses than the 300 3 times a day. Yeah. Yeah. Yeah.
Neurologists use the drug very differently. They will start the drug at night, maybe 300 milligrams, and then gradually increase the dose to 6, 9, 1200, so that if there is going to be fatigue, it will happen at night. Yeah. It's very interesting that different subspecialties use it so totally differently. So is there any attempt by oncology to confer with the neurologists a little bit more to use it in that way so that it does not cause that daytime fatigue if it actually has an effect just using it?
I think that's a very good point. I think you're absolutely right. I actually use the nighttime dose for the women that have the hot flashes and night sweats, because it's, usually it's the nighttime symptoms that are most bothersome, don't let you get sleep. So again, I usually try 100 for a week and then go to the 300 at bedtime. But I haven't done that for the neuropathy, and you're probably absolutely right. So I think the key for Neurontin is it's an interesting drug. it's worth playing with and working with because it can be very active for several things, not just this. And I don't, just because someone has depression doesn't keep me from potentially trying it.
So
But thank you, I think that's a great thought.
Sorry, that was my question. But the question I have is, when you prescribe Neurontin and the patients already have a history of depression, do you change their antidepressant medicine, or do you prescribe it alone, like to work with Neurontin?
I tend to prescribe it along with, in addition to whatever they're on. But I would tell you that most oncologists are not very comfortable doing much changing of antidepressants. I think we are not good at it. I'll speak for myself. We have lots of new antidepressants, and I think you need to know the nuances if someone's got more depression or anxiety. So I often, when I'm getting out of my depth, I go to the psychiatrist or oftentimes the family doctors. The primary care physicians are often very knowledgeable about management of antidepressants. So I rely on them to work with me on those things, because I just don't feel comfortable with some of the newer drugs, the combinations. And again, that's also what palliative care physicians are very good at. So oftentimes when I send patients to my palliative care colleague, they're very helpful at adjusting and merging antidepressants.
So as a follow-up question that we received from someone else, have there been studies of antidepressants specifically in women with metastatic disease? Do we have any information about which medicines might work better and interactions with other hormonal therapies, for example, that people might be taking?
So there have been studies. I can't comment on the results of specific studies because it's not something that I've really looked at too closely. The big concern in the past, and I think it's still probably a concern, although I think it's sort of lost some of its glamour, were the relationships with tamoxifen. In the past, we focused a lot on dividing the antidepressants into those that had large interactions with tamoxifen, intermediate or low interactions with tamoxifen, and you picked the ones that interacted the least. I don't know that there are many women with metastatic disease on tamoxifen these days, because if you're very young, we often will do something to ablate your ovaries. So I think this is more of a concern for the early stage breast cancer and the interaction with tamoxifen. There actually was a phase where we were testing women for metabolizing pathways, because we know that you have an inherent way of metabolizing tamoxifen, like probably many other drugs. There are people that are rapid metabolizers, there are people that are slow metabolizers, and it was thought that your profile would predict whether you got benefit from tamoxifen or not. So probably for 5 to 10 years, there was oncology debate. Every meeting you'd go to, you'd hear a group talking about, yes, we should do metabolizing profiles, and then if you're not, if you're a rapid metabolizer, great. If you're not, blah, blah. And then all of a sudden, some of those same researchers started looking at their data again, and there wasn't that much difference. So I think that pretty much went out of vogue the last 2-3 years. But yes, I think there are definitely antidepressants. It's tamoxifen, really. There are no interactions with other drugs that I'm aware of, with other aromatase inhibitors, or even with Faslodex. It's tamoxifen and its metabolizing pathway. But I am not aware, and Kanu may know more, about specific trials with specific antidepressants in metastatic disease.
Thanks, Dr. Grana. Our next question is about hand-foot syndrome and methods to manage that. And this person is also asking whether folic acid should be avoided because of it.
So, avoiding folic acid. Yes, it's part of the pathway, but I don't know that giving folic acid would interfere with the effectiveness of the drug. I can't answer you because I'm not aware of any data about the folic acid. Hand-foot syndrome is particularly annoying, especially because Xeloda, it's not the only drug that causes this, actually. Doxil, for some of you who've been on the adriamycin-like compound, liposomal doxorubicin, Doxil, also causes this in a significant number of patients. And then there are those patients who are on Taxotere or Taxol that get a milder version of this. But it's really redness, peeling, blistering, pain, hands and feet. It can start off very mild, and it can become very significant. And it seems to be particularly problematic. I've had patients who had little and well-controlled, and then went on a large hike and didn't necessarily wear the best shoes and really got bad symptoms. So it can be very problematic and very painful. The key is we have no other strategies other than lathering with any topical lotion. So udder cream and some of those things that come. Actually, the people that make Xeloda put a packet together with some of those things. I think they're very helpful, but oftentimes it's changing your cycle and changing your dose. So as little as dropping the dose, 500 milligrams can be a world of difference. Some people use Xeloda on a 2-week on, 1-week off schedule. Other people use it on a week on, week off schedule, and the schedule often can make a difference. So it's a critical thing to learn to manage because some patients can stay on that drug for a couple of years. So you really do have to get it under control. But I can't answer the folic acid.
I think NCI is a part of it, and UPenn is a part of it, because my patient was trying to see if she could be enrolled in that study. But that's more looking at if Neurontin enhances the antidepressants in terms of managing the hot flashes.
If it improves the management, Neurontin
if it
and
improves the
antidepressant.
management of adding Neurontin.
Yep.
And they are using mostly like Effexor, the venlafaxine, because of this whole interaction of the antidepressants with hormonal therapy with tamoxifen. They're also looking at Lexapro with it, which we generally don't use. We try to avoid when people are on tamoxifen. But that's the only thing I certainly remember.
Right.
Our next question is about photosensitivity that you had mentioned as a side effect on one of your slides. Can you address the issue of cancer treatments that could be associated with photosensitivity, as well as how to handle that side effect?
There's not a lot of great data about this. We tend to see it more with radiation, so radiation sensitivity or radiation recall. And it tends to be in people that have had adriamycin. You can see it a little bit with Xeloda. You can see it less with the taxanes. So it's the concept that if you've had radiation, if you've had these drugs and then you get radiation, you can actually get redness in the site of which there was radiation. I do worry because I think many of these drugs, Xeloda, adriamycin, can affect photosensitivity, but I don't think there's a site that I can guide you to in terms of which ones are worse. There's just not much that's, I think, been published on this, or at least that I'm aware of.
Thank you. Our next question, again, is about Xeloda. Have you heard of Xeloda causing loss of taste buds or a bald spot on the tip of the tongue? And are there any treatments for that condition?
Interesting. I have not heard about this, but I wouldn't be surprised. I think, change in taste is common for many chemotherapy drugs, and Xeloda is a chemotherapy drug. No, I'm not aware of, I haven't seen that as a complaint.
Our next question is about some of the complementary and integrative therapies. A caregiver is saying that his wife's oncologist ruled out massage therapy for pain management because she has lymphedema. Do you think it would be safe to use acupressure or acupuncture in that case?
So massage therapy, what would be the concern? We actually use a variant of massage when we treat lymphedema. So when you send women for manual decompression, which has been one of the mainstays of lymphedema management, it's basically that. It's basically massage, deep massage, to sort of move the fluid up, and then you wrap the arm to keep it that way. So I can't envision that there would be a downside to massage in someone who has lymphedema. I'd be a little bit concerned, though, about the acupuncture, because remember, they're needles, so they're very tiny. But again, I would minimize anything that is gonna potentially introduce bacteria into this arm. I have patients that I sort of urge when they're having their nails done that they either have their own supplies or make sure they're sterile. So you really want to minimize anything that could seed infection into that arm.
I'm a hand therapist by training, and I just, and I also had the beginnings of lymphedema and hit it with Levaquin pretty quickly, and it just went away. But in the course of, I'm trained, and I also went to a PT who's trained, and I suggest that if you're going to look at massage therapy, you just make sure that you're talking to someone who has done lymphedema training, because it's a very specific way of doing it, and the lymph vessels are so, minute and so sensitive that you can damage the lymph vessels. So when you're looking at massage therapy, it's great, but you really should go to someone who's trained.
I think that's a very good point. That's a very good point. But I definitely would not approach acupuncture. I think acupuncture would really worry me in the setting of active lymphedema.
Thank you, Dr.
And I like
Grana.
the concept of acupuncture for many other things. I send women for evaluation for hot flashes and night sweats, potentially neuropathy, some of the arthritic symptoms. So I am a believer, but that one would scare me.
Our next question is about osteonecrosis of the jaw. I'm not sure whether this person was interested in prevention or treatment, so maybe you could talk about both.
So I've been doing this long enough that I remember the world before osteonecrosis of the jaw. So probably about 8 years ago, I had a patient who had her teeth pulled, an older woman, and she comes back to me with the first published article on 60 patients reported out of a hospital in Long Island that developed osteonecrosis of the jaw on bisphosphonate therapy, Zometa, Fosamax, Boniva, any of the bisphosphonates. Now, with the orals, it was case reports. Most of them were on Zometa or Iridia in the old days. So we've come a long way. We now know that it's an issue with any of the bisphosphonates, equally an issue with Xgeva. We don't know really, we think that the prevention is appropriate oral hygiene, dental exams every 6 months, not instituting it in someone that you know is going to have teeth pulled, avoiding that kind of thing. But once you've instituted the drug, we also don't know that there's a great way of preventing it further than that. Once someone is on the drug, and we often will stop it for a while if they're getting a tooth pulled, but we don't have any data that says that that's going to cause healing any better. So I think it's a problem, and it's a very important drug in the management of both potentially early-stage breast cancer and metastatic disease. Once you have it, it's a real dilemma. So most patients have a small site, so they'll have one tooth, and it just doesn't heal, and you see pieces of the root, and it just doesn't heal. In the patient who's had multiple extractions, those can be really difficult. Antibiotics, sometimes IV antibiotics, debridement by a good oral surgeon, hyperbaric oxygen has been used. The key is working with a very good oral surgeon who can help to manage this. But it can be problematic. Canu, anything else? Yeah, I think dental clearance. And this is interesting because we are using bisphosphonates and Xgeva Prolia, which is the non-cancer form of giving Xgeva. We're using it now in early stage breast cancer patients, and there's data that you may actually improve survival in women who are on an aromatase inhibitor and bisphosphonate therapy in early stage breast cancer. So if I'm going to do that, and I do it selectively because I think the data is still not great. But if I'm going to do it, I actually send the woman for dental clearance and then start the drug. The gynecologists who are also prescribing these drugs are not doing that. And I think it's because we come at this burned from the Xgevas and the Zometas, and the gynecologists don't have that same experience. So I think dental clearance, dental ongoing management are the key.
Thanks.
Right. Yeah, yeah. I think, yeah, you're right. You're absolutely right. You're living. This is a wonderful thing. And so we're starting to see some of these issues that are problems. Now, what are people doing? So, the data on the drug, on Zometa and Xgeva, was 3 years. 3 years was the duration of those studies. So what do we do with you when you get to the 3 years? It's no man's land right now. There was a study done that looked at Zometa monthly versus every 3 months. We don't have that data yet in metastatic disease. We don't have that data. But if we find that the efficacy is the same, it'll be important to see what happens to the other side effects. I tend to, when I get to the 2 to 3 year point, start spacing it out. So start spacing it and maybe do it every 3 months for, I have someone who's been on 5 or 6 years, and I stopped it. So I did it for monthly until she got to year 2, every 3 months until she got to year 5, and then I stopped it. But it is purely flying by the seat of your pants because there's absolutely no data that has looked at anything beyond 3 years.
Thank you.
Hi. I just was curious about some side effects from navalbine with Herceptin. I just wondered if you had heard anything, or had experience with people getting severe migraines as well as nausea that lasts weeks, intense nausea lasting weeks after the infusion. I'm speaking from personal experience recently, and just wondered about that, if that sounded like normal sort of clusters of side effects to you.
It's interesting. It's one of my favorite regimens. Navalbine and Herceptin is one of my all-time favorite combinations with great activity. Dana-Farber reported it. It might be worthwhile going back to that Dana-Farber article if you can find it. Eric Weiner was the first author on that. And seeing if they had any significant reports of this. I can't say that I have. I have had people complain, and I wonder if this is could be. I've had people complain of GI toxicity with navalbine, bloating, nausea, and I think it's because navalbine is it's a neuropathic compound. It can cause neuropathy, and you have this plexus that controls the gut. So constipation can be seen with neuropathy. The bowel's not moving well because of its neuropathic component. I don't know if that could be the explanation. But no, usually I find that it's very well tolerated. Again, I come back to the concept that navalbine has neuropathic. It's a vinca. It has neuropathic properties. And I wonder if that's the mechanism. And if it's bothersome enough, there's so many other drugs that you can use with Herceptin that may not be your best drug. But I haven't experienced it.
Thanks, Dr. Grana. We have one last question, then if you have any closing remarks. We had one person asking about methods to manage pain related to surgery, so mastectomy pain.
Post-mastectomy pain. There's a woman who worked with us, and now she's the head of the palliative care program at NIH. Her name is Ann Berger. And she was very, very interested in post-mastectomy pain. In the old days, probably up to 40% of women could be, when questioned and surveyed, had post-mastectomy pain. I don't think we see it as much anymore, and I don't know why. I don't know whether it's because we're not doing the same radicalness of the procedures. I don't know, but I don't think we're seeing it as much anymore. But you still see it plenty. And there are no great interventions. I send these patients to pain management. Our pain management team, some people have used specific blocks, nerve blocks. We had a young woman who was interested in topical ketamine, much like that when you look at the ASCO guidelines, they talked about that baclofen, ketamine, amitriptyline concoction. She was doing something with ketamine and something else. So it was a sort of their own homegrown topical anesthetic, and some people got great relief, but there's not great management for this. So these are patients that I think really benefit from going to a pain management team and trying different strategies, but it can be problematic.
Thank you so much. Any closing remarks?
Other than I'm humbled because I have no answers to most of your questions. You know, metastatic disease is a very complex world. There are so many new drugs, so many side effects that we're learning about as you're learning about. These are new combinations, new drugs, and the key is we need to do it together. So I want you to tell me about the side effects so that I can try to investigate how to fix them. And I think the communication with your oncologist is critical, and having them help you find the resources, because there are palliative care, integrative medicine, neurology, all of those are resources, psychiatry, and really helping you find those resources is what they should be doing. So it's a pleasure to be here. Thank you.
Thank you so much, Dr. Grana. So I just have a few closing remarks and announcements. First of all, thanks very much to Dr. Grana and to all of our speakers who were here this weekend. Some of them are still in the room. I hope that you're going to be leaving here feeling that you've connected with some people, that you've gotten some information that you can take back to your healthcare professionals and have some really good conversations about the ways you can move forward. A couple of reminders. We will be emailing you an evaluation after this conference. It's very, very important to us that you fill that out. We take every evaluation very seriously in thinking about future programming, so please go ahead and do that. Please keep in touch with us. We have some upcoming programs focusing on metastatic breast cancer, including a webinar in July that will focus on accessing clinical trials and learning more about them. So I hope you will join us for that. After I'm done speaking here, we're going to have a closing reception. I hope some of you will join us before you leave. And just a couple of logistical announcements. Could Kathy Hall please wave her hand? If you are in here, Kathy Hall, can you please wave your hand? I guess Kathy isn't in here. Okay. And my next message of that nature is for Amanda Gill, who should report to the lobby to pick up her rented car. Very important. I also wanted to announce the winners of the drawings. The designer set of hand wraps will go to Shauna Brown, ticket number 509311. Yay! Stand up and take a bow. Thank you, Shauna. The Radiant Wrap designer gown will go to Paige Morcha, 509362. Paige, are you in the room? I don't see Paige, but... Oh, wait. Oh, there she is. Let's give her a hand. The White House Black Market Prize package will go to Maru Gonzalez. Maru. Congratulations, Maru. The luxurious plush wrap will go to Ruth Hughes. Ruth, are you in the room today? Yay. Congratulations, Ruth. And finally, the Living Beyond Breast Cancer prize package will go to Sheila Smith. All right, Sheila. A couple more announcements. If there are ladies here from the Inspire Online Advanced Breast Cancer Support Group, could you please stand? We had meant to connect all of you earlier in the conference, and we weren't able to do so. So we just want to give you an opportunity to see one another if you haven't connected already. Thank you. And just a reminder that we do have a train shuttle that will be leaving the hotel at 1:30 for the Residence Inn and the Conshohocken train station drop-off. So with that, I just want to thank all of you, say what an honor it is to be able to provide programming for you, and for all of you to come here from all across the country for this weekend every year. It's a beautiful day outside. I hope that before you leave our area, you'll look up at the sun and take a deep breath and just walk away with this quote that Sherry Lebed Davis left with us yesterday. Your day belongs to you. Make it as beautiful and as wonderful and as happy as you feel today. Thank you very much, everyone.